Good afternoon and welcome everyone to the third annual Virginia Funders Network Conference. We look forward in giving a hand to the outstanding VFN small but mighty team that has pulled it off. Atkins-Rowan, and I have the honor of leading the Weisberg Foundation. I'm here today with two of our trustees, founding trustee and investment committee chair, Nina Weisberg, and independent trustee and investment committee member, Edward Jones. Thank you so much for coming. Today we are in a historic city, Richmond, Virginia, and I can't start without saying that we are on the unceded land of the Powhatan Confederacy, which counts a number of tribes as members. We owe them a historical debt for the place we gather. I pay my respect to the elders and descendants who have stewarded these islands and waters since the beginning. I also want to acknowledge the Africans that were enslaved on and transported from this very land, where between the late 17th century and the end of the Civil War, Richmond was the second largest domestic slave trade site in the country. This is also the place that post-Reconstruction implemented some of the most drastic Jim Crow laws and policies and served as a literal monument to the lost cause until very recently. There is history all around us, and I do hope that you took time to explore the Virginia Museum of History and Culture, that in your own walks, you go to Shockoe Bottom or to Browns Island. But never fear, because in today's session, you will learn about how Richmond's history continues to impact her citizens today. I have the privilege of introducing the moderator, but before I do so, I'd like to share a bit about the foundation and why we thought today's plenary conversation, building a more equitable future, philanthropy's role in health and racial equity, was so important. The foundation advances organizations and efforts building the power of those most negatively impacted by racism. We honor three core commitments. We center Black, Indigenous, and communities of color in our work because racial identity remains the #1 predictor of life outcomes across almost every dimension in the Commonwealth and in the United States of America. And these inequities exist because of structural racism. Structural racism refers to the ways in which policies, institutions, practices, and other norms work in various and reinforcing ways to perpetuate racial group inequality. We focus on power building because we know it's critical to transforming systems that disproportionately impact Black, Indigenous, and communities of color. Power building is a process by which communities impacted by structural racism organize to realize their community visions, set agendas, and change systems to build political power, economic opportunity, and social inclusion, and hold systems and institutions accountable. And we focus in the Commonwealth because as the birthplace of Indigenous forced land removal and genocide, as well as chattel slavery, Virginia played a central role in the codification of racial hierarchies and the implementation of racist policies that have compounded to produce the racial inequities we see today. It is important for us to reconcile this history and the Commonwealth's central role. The foundation is activating 100% of our assets in support of our mission, vision, and values. We are investing in innovative grant making, investing for impact, internalizing racial equity, and influencing philanthropy, which brings me to today's plenary session. As one of my former colleagues thought about how we might influence philanthropy to increase a focus on racial equity and justice, he conducted an analysis to see which issues were at the forefront for BSN membership. And it turns out that a plurality of our members have some commitment to health. And so the idea for this session was born. A session that will touch on a topic that is relevant for large group of funders in attendance, that will allow us to speak to the history of structural racism and racial health inequities in our host city and across the Commonwealth, and that will provide a space for our fellow colleagues to share their stories about their foundation's role in health and racial equity. I hope you'll agree with me after this session that we hit the mark. And now I'd like to introduce the moderator for this plenary, who really gave no introduction and was so committed to being a part of this conversation, the President and CEO of Virginia Center for Inclusive Communities, Jonathan Zerr.
Good afternoon, everyone. Really honored to be with you and to both wear the professional hat that I have the honor of wearing at the Virginia Center for Inclusive Communities, and also a newer hat as a new trustee for the Richmond Memorial Health Foundation. I'm grateful to all of the RMHF staff and trustees who are here today. This afternoon's conversation is going to begin with a presentation that will help us to localize our awareness of health and racial equity, and will then engage a panel that will explore different ways that foundations and institutions are thinking about health and racial equity in different corners of the Commonwealth. Before I introduce our speaker, who will kick things off, will you join me in thanking Rashawn and the Weisberg Foundation for your incredible investment and example? If you don't know our speaker, you are in for a treat this afternoon. Sheryl Garland is a remarkable leader, visionary, powerhouse in the Richmond region and beyond. Professionally, she served as Chief of Health Impact for VCU Health System and as Executive Director of the VCU Office of Health Equity. As Chief of Health Impact, she is responsible for building programs and partnerships to improve the health of populations and communities served by the Virginia Commonwealth University Health System. In her role as Executive Director of VCU's Office of Health Equity, Sheryl leads a team that integrates principles of health equity into VCU's core mission. She is a fellow in the American College of Healthcare Executives and a member of the Sister Fund and African American Women's Giving Circle. She serves on the State Board of Social Services and the boards of the Community Foundation for Greater Richmond, the MCE Foundation, the American Heart Association Richmond Affiliate, the Virginia Center for Health Innovation. She's chair of the board of the Institute for Public Health Innovation and a trustee emerita for the Richmond Memorial Health Foundation. She has received numerous awards for her engaging community work. Sheryl received her undergraduate degree from Wake Forest University and a master's in health administration from VCU. Please join me in welcoming to the stage.
Thank you, Jonathan, for that introduction, and thank you, Rashawn, and the Weisberg Foundation for sponsoring this luncheon. I have the privilege and the honor today chatting with you guys about the role of philanthropy in health and racial equity. And it's good to be amongst some new friends, because I have to tell you, and I've told several of you that I am so nervous. So please forgive me if I stumble as I go along, but you hopefully will get my passion. We're going to start with some grounding and terminology. What do we mean by racial equity? It truly is the systematic, fair treatment of all people that results in equitable opportunities and outcomes for everyone. What's interesting about racial equity is that it's not just the absence of discrimination, but it means that there also has to be some embodiment of values and systems that really support ensuring that there is fairness and justice for everyone. Health equity as defined by the CDC and the World Health Organization. Really, the idea, the principle that everyone has a fair and just opportunity to be as healthy as they can be. And recently, I was at a meeting at the Richmond Memorial Health Foundation, and I got really excited when I also saw a posting of their definition, which started with the CDC definition, but also been expanded to say that health equity also requires the engagement of communities and partners to focus on reducing health disparities and removing those obstacles that are really impeding achieving optimal health. And I'm sure many of you have seen the infographic that is on this slide that shows the difference between equality and equity. Equality essentially is everybody gets the same supports, regardless of where you started from under circumstances. Equity is focused on providing specialized tools and supports, meeting you where you are. I would say to everyone in this room, we really should be focused on justice. And in this infographic, it's taking down ethics so that everyone what are these health disparities? Health disparities, first of all, are invented. Is anyone that tells you otherwise, please question where did they get their definition. Health disparities are those differences in health, and they are closely linked with economic, social, or environmental disadvantage. And often we see infographics similar to what is on the slide that demonstrate to us that when you take a look at what is going on with populations in comparison to others, you can look at the differences that exist. And this particular infographic is focused on disparities that exist in different health conditions. Where do these disparities come from? What are the drivers behind them? I was so excited many years ago when I found this model, the County Health Rankings model, and hopefully if you have not seen it, you will take the time to go and really spend some time like understanding what it is. It was developed by the University of Wisconsin's Population Health Institute many years ago. They generate a report every year for each state across the country. And essentially, the County Health Rankings model basically says if you look at health outcomes, which can be measured by how long people live and their quality of life, and there's specific metrics behind it, there are essentially 4 factors that lead to health outcomes, and those factors are undergirded or supported by policies, practices, and systems that exist in communities across the country. Those factors can be divided essentially into 4 categories. First, they're related to health behaviors. Do you smoke? Do you drink? Do you exercise? These are personal choices that represents about 30% of the factors. Then there's clinical care. It's depressing to many of my clinical colleagues when I tell them that only 20% of the factors are really related to clinical. That is access to care and quality of care. But then when you start to look at the social and the economic factors along with physical environment, collectively, those factors represent about 50% of the issues, the conditions, the situations that people encounter that ultimately impact their health outcomes. These collectively are known as the social determinants of health. And they exist every single day. The technical term I use is it's the stuff that's going on in people's lives that has an impact on how long they live and their quality of life. This is the 2024 Health Outcomes Map that was recently released for Virginia. The way that it is set up is that the darker green shaded areas are the healthiest communities in our Commonwealth. Those that are gold or tan are those that are the least healthy. You can see that we live in a very diverse Commonwealth, and depending on where you live, there are very different outcomes and situations that the people that you serve are encountering. So the question that we should all ask ourselves is how did we live? I would dare to say to you that whatever is happening has grown up over time in the 400+ year history of our country. That the reasons for why we are here have grown up in societal norms, in our values, in our history, in our laws. There's an interesting quote that's been said by many different people in various ways. But I would share with you today, if you don't remember anything else from this discussion, that those who do not know their history are truly doomed to repeat. So it is important that we understand what are the factors that got us. So I'm going to start with racial disparities. And as Rashawn so eloquently laid out, this is the perfect place for this discussion on this day. Because if you think about it, a lot of the racial health disparities that we see are really grounded in the history of this country. And I'm going to start with this map that shows you where Jim Crow laws were adopted. These laws, which were on United States books for 100 years or more, were essentially established in the South, Midwestern states in a minute to create segregation, to embody it into our laws, our policies, our system. And it created this system whereby people were denied access to services, to essential activities such as voting, and even healthcare. It's sort of interesting. Don't think very often about the impact of legal segregation on healthcare, but I would share with you today that it was profound. First of all, legal segregation restricted access to care. There were actually hospitals that Black people could not go to. And in fact, in this picture, I shared with you a picture of St. Philip Hospital, which was built in 1920 to care for the Black patients who came to the medical college. At one point in the hospital's history, Black patients were seen in the basement of Memorial Hospital. And the local media began to write a series of articles about the deplorable conditions of the bad infested units, which led the board of directors for the Medical College of Virginia to commission the building of a separate hospital that opened in 1920, but then they had to commission a separate nursing school in order to train nurses to care for the patients who were seen there. Unfortunately, no Black physicians were allowed to have privileges in that hospital. It also influenced the design of physical facilities such as separate waiting rooms or even education pancake waiting rooms so that Black people and white people couldn't sit in the same streets. And then we think about how legal segregation had a huge impact on the mistrust we see in medical research. Thinking about the Tuskegee experience, or what happened with Henrietta Lacks, and the collection of her cells when she went to Johns Hopkins prepared for cervical cancer, and how those cells, because they were so unique, were used in research. And to this day, there are over 70,000 studies that are associated with her cells that are so unique, and over 110,000 papers that have been given millions of dollars that biotech companies have made off of the collection of her cells without her knowledge or her permission. What we've seen, especially in the late 1800s and early 1900s, is the outcome of this separation of these institutional, systematic policies that were put in place, which led, even in the early years of our country's history, to the documentation of the disparities in life expectancy, infant mortality rates, even death related to diseases, for which there were cures that we have. This infographic, I know it's hard to see, but I wanted to put it up here just as an illustration. Now, again, I'm a hospital administrator, so I'm really grounded in data. Why did hospitals ever come to be in this country? It's very interesting. This is a timeline of the growth of hospitals in the Richmond area, starting from close to 1840 up to about 1960. The importance of this slide is, first of all, that in the 1700s and early 1800s, people didn't go to hospitals. You only went to a hospital if you were poor and if you were about to die. People were cared for. And then somewhere around the mid-1800s, hospitals became kind of innovative. And people started going there for care. What you can see on this slide is the eventual growth of hospitals, especially through the 1800s, early 1900s, in the Richmond area. What I want to point out to you is the colors in each of the boxes associated with the hospitals. While there was an insurgence of growth of hospitals in the middle 1800s, early 1900s, there were specifically for health patients. There were a couple of hospitals that were built for Black patients, and very few integrated hospitals, really until you got to about 1957, when the physicians and administrators who were bold enough, Richmond Memorial Hospital said, we need to stop this and find a place where Black patients can be seen and receive equal treatment like White patients. There's actually an ad in 1922 for VCU Hospitals. Now, VCU as a medical college was established in 1838. Thrived through the Civil War because there was a propaganda campaign to bring back the medical students who were in the North and didn't agree with the Northern philosophies. But the hospital itself maintained segregated facilities. And as you can see, there was a hospital specifically for white children. There was a hospital specifically for white patients. And then, as I mentioned, the St. Philip Hospital, which was built in 1920, specifically for Black patients. Very interesting, though, there was a group of Black physicians and supporters in Richmond who said there has to be a different way to provide care to African Americans in Richmond. And what happened in about 1905, 1907, Dr. Sheryl Garland started a hospital in Jackson Ward, historic Jackson Ward. And then, with the help of the women's auxiliary of that hospital and Richmond Union University, they were able to build a building on Richmond Union's campus. And it was a 25-bed facility that opened up around 1925, 1927. And it thrived until 1980 when it moved to Richmond's East End. And in 1990 it was actually purchased by Barbosa. But the reason that this is so important is it provided a space for Black physicians to practice, as well as it also started a nursing school that provided an opportunity for nurses to be trained. Interestingly enough, there was very little federal legislation of funding that went into establishing hospitals that were built by private groups, private organizations. And then in 1946, there was a realization in the Truman administration that there was a problem across this country, especially in rural areas, with a lack of hospitals. And in 1946, there was a bill passed called the Philanthropy Act, which actually began to infuse dollars into communities across the country. And the one criteria that hospitals had to agree to is that they would provide free and charitable care to uninsured and low-income individuals. By 1975, the Philanthropy Act was actually responsible for about 30% of all hospitals that were built in this country. But this was also an interesting act because as a part of that legislation, the federal government codified the concept of separate people. That hospitals that received Hilburton dollars were given the leverage in order to build separate facilities and to separate Black patients or patients of color from white patients. This stood in place until the Civil Rights Act of 1964 was passed, in which case, for those of you who are not entrenched in your history, basically it was legislation that said any federal dollars cannot be used to promote racial segregation in this country. Unfortunately, there were very few federal programs that were targeted towards healthcare. And during 1965, there was a major campaign that went on at the federal level to look at the passage, the adoption of Medicare. And there is an interesting component to the Medicare legislation that basically said any hospital, nursing home, or private practitioner who agreed to accept Medicare and Medicaid dollars could not discriminate based on race. And I'm not sure how many of you realize that the Medicare Act of 1965 was actually the leading legislation to end segregation in hospitals in this country. So, think about it. 1965, we said everybody should have equal access, right? Everybody should have equal access to care. But then in 2002, this landmark report from the Institute of Medicine, which is now the National Academy of Medicine, was published. It was called Unequal Treatment. And what the book essentially, or the report essentially said, is when you look across this country and you look at what is going on with the outcomes in healthcare, what you see are differences, major disparities between health outcomes for people of color and white patients. Do we understand our history? And do we understand the drivers behind health outcomes in our country? In fact, the CDC has spent a great deal of time, Centers for Disease and Control, spent a lot of time tracking data and really trying to help people understand that where you live matters. And if you have a better memory than I do, and remember the map of where the Jim Crow laws were adopted, you will see that this map, like a couple others that I'm going to show you, mimic that map. And where we continue to see today difficulties and disparities in life expectancy rates in communities mirror where it is we continue to see large numbers of minorities, individuals who have low socioeconomic status, indigenous populations, and immigrant populations. As we begin to uncover some of the issues behind some of the major reasons for death in this country, like heart disease, we again continue to see the high prevalence of high mortality rates in the same communities where there were issues related to racial segregation. And even today, when you begin to uncouple this data, you see the disparities that exist between minority populations and majority populations. So closer to home, I am so blessed and so fortunate to work with a group, the VCU Center on Society and Health, that was given from me by the Robert Wood Johnson Foundation to publish maps in cities across the country to take a look at what was going on in those communities in regards to life expectancy rate. This is a map of Richmond that was published a few years ago. And the map essentially shows that if you live in Gilpin Court, which is about 10 minutes from downtown Richmond, your life expectancy rate is about 60-30. But if you go 5 miles across the road to the Westover Hills community, your life expectancy rate is about 83, a 20-year difference within 5 miles. And this same scenario can be seen in cities across the country. And the question is why? My colleague, Dr. Rob Wayne, who's the director of the National Comprehensive Cancer Center, shared with me about a few weeks ago. And he basically said your ZNA, your zip code or neighborhood association, can have just as much of an impact on how long you live as your DNA. Why? Why? What is it that has gotten us to this point? I don't have to, I'm sure, for many of you, tell you about redlining. And as you know, back in the 1930s, right after the Great Depression, the federal government actually supported this institution of a program called redlining, in which financial institutions under the guidance of the Home Ownership Loan Corporation actually went into neighborhoods and they drew maps all over the country. And what they did is they color-coded the neighborhoods and they gave them a grade. So those neighborhoods that you see on this map that are in Commonwealth are the best neighborhoods. These are the ones that got a grade of an A. Those that are B, or the blue neighborhoods, they're desirable. They're still good neighborhoods. When you get to the yellow neighborhoods, they are neighborhoods that were defined as definitely declining. They were in transition. They were in a transition period because of age, obsolescence, or the infiltration of a lower grade population. I wonder who were they talking about? And then the red neighborhoods. These were the ones that got a grade of a D. They were classified as hazardous or risky. They had fully declined, and they were characterized by detrimental influence and a pronounced degree. Let me share with you that all but 2 of the grade D neighborhoods were minority neighborhoods. They were all. So how was this played out? Why is it important to understand our history? Because when we look at the maps of where there's the highest rates of poverty in the city of Richmond, many of those communities are communities that have C or D. And when we look at the health indicators, where it is we see the highest prevalence of chronic conditions and death rates, or that are related burdens, right, and lower life expectancy. It's in those communities that have grade C or D. The good news is the American Hospital Association several years ago realized that there were some major issues that hospitals were trying to grapple with, and they needed to start with understanding the communities that they served. This is a framework that was provided to its members to really help on the journey of thinking about health equity. It starts with the person, the patient that you're caring for. This is where we start thinking about health-related social needs. Does this person have food insecurity or housing instability? But then, the American Hospital Association said, hospitals, get off your campus, look outside your walls, look in the communities, and look at those factors that are influencing the communities, the social determinants of health that we talk about so often. And then if you want to be really bold, look at the systemic issues. Think about the advocacy role that you can play in order to begin to address those issues. A couple of years ago, VCU Health System decided to take a look at what was going on in its communities and set about strategies to really do something in a space that we weren't comfortable in, a space that was outside of our core mission of providing care. And we started with who we primarily serve. 22% of the patients who come to VCU Health, our flagship hospital in downtown Richmond, live in the city of Richmond. So we looked at this dashboard that was developed by the Richmond Department of Health. Dashboard with its 6 factors was shared, developed for communities across the Commonwealth, and gave it a color-coded score. If you had blue bar, then you were dealing with issues that were below the median for the entire state. If you had a blue bar, you were faring better. As you can see, the city of Richmond did not get such a good scorecard on this dashboard. Made us think we really need to start thinking about strategies. And so we started building strategic partnerships to address some of the issues that our patients were presenting with, whether it was legal issues or housing issues or food insecurity. And we also realized that we're one of the largest employers in the city of Richmond, in the whole metro area. So what were we doing from a workforce perspective? Interestingly enough, And this will be probably one of the only times, and I know I'm amongst 300 friends here, and you won't let my secret out. But it's one of the few times in my life when I was excited when a couple of regulatory agencies came knocking on our door and said, you shall do something about that. And in 2023, the Joint Commission, which accredits about 80% of hospitals in this country, and the Centers for Medicare and Medicaid Services, which provides oversight for Medicare and Medicaid programs, both release standards and regulations that said the hospitals must address health equity. They've given us guidance about advancing health equity as a part of our strategic plan, doing screenings for our adult day patients around 5 health-related social needs, and documenting the results in our electronic medical record. And our teams have said it's not enough to document. We need to do something. Go look for the disparities and then develop action plans. This is such an important issue for the Joint Commission that in July of last year, they transitioned those leadership standards to one of its 16 national patient safety goals, and CMS has begun to roll out new human models for hospitals and physicians. You talk about incentives. So, in closing, what I'd like to share with you is a couple of thoughts for you to take into the rest of this session. First of all, it's important to understand your history and recognize the impact of that history, historical programs, policies, values, on what we see today in some of these health indicators. And we need to understand the intersection between racial and health equity because it's undeniable. And if we're going to be serious about addressing health disparities, then we must pay attention to the social and the economic issues that stuck in the lives of the individuals that we're touching. The social determinants of health, they are present and they are real and they are barriers to achieving health equity. And finally, thank you to my friends at the Richmond Memorial Health Foundation for acknowledging that the development of community partnerships is a key factor if we're really going to be serious about addressing health disparities and improving health in the communities that we serve. And that's where each of you come into play. You are the drivers. You can pull it all together and you can pull the partners together. And with that, I want to say thank you. I'm going to turn it over to
It's always nice to hear some well-deserved woos, so that's some woos from the crowd. Certainly a lot to think about as we consider the residue of our past, the implications for our present, and then as we explore what we might be able to do through philanthropy moving forward. And so now I'll invite our panelists to come up, and they will be able to share a little bit about how they and their institutions have entered into work connected to health equity. So please join me in welcoming Cecilia Barbosa, a trustee with the Jenkins Foundation, Cynthia Romero with the Eastern Virginia Medical School, Pat Matthews, recently retired from the Northern Virginia Health Foundation, and Maggie Richardson-Mackerman with the Health Collaborative. Welcome our panelists. We have a distinguished panel, and I'll invite each of you to begin by sharing a little bit about your path to engaging racial and health equity personally and through the institutions you represent. Cecilia, you want to get started?
Well, good afternoon, and I am here representing the Jenkins Foundation. I want to also acknowledge my fellow board members here, and several of who are also present here. And good to see you. So in terms of our path to addressing health equity, it has come from both many directions. It's really a path individually as well as a team. Both individually, I think that we have focused on learning and appreciate Cheryl's presentation today. I think there's a philosophy amongst us of continuous learning, and every time I'm hearing, we are ever more conscious of the importance of our work and the work in health and racial equity. So as a group, we also have evolved. We've changed the composition of our board as people have left. We have been very consciously and intentionally looking for people with either deep connections with their community, as well as people who also have perhaps are newcomers to the area and also bring a different perspective, a new perspective. So getting new voices into the room has been super important. In terms of one of our values, as we did our strategic planning, has been equity. We established that as one of 3 values, along with learning and legacy. And most recently, we had defined equity as, and I will read this, we believe all people should have equitable access to quality healthcare and resources. And recently, with new members, new learning, we just changed that to, we believe all people should have fair and just opportunities to achieve their highest level of health. We believe that historical and contemporary injustices and racism have contributed to health disparities in our community, and we actively seek to help heal these systemic harms. As you can see, a drastic and very important change, and reflected, and because of our learning and new membership on our board.
Thank you. Cynthia, your personal and your institution's path to health and racial equity.
Sure. So good afternoon, everyone. Thank you so much, Virginia Funders Network, for having me and to be sitting here amongst 3 incredible other panelists to hear Cheryl's presentation. It's really motivating. So I'm actually a professor of family and community medicine and the director of the Broad Institute for Community and Global Health at Eastern Virginia Medical School. And Jonathan's great question of why I personally went into this work for health equity and advancing all efforts to eliminate health and healthcare disparities. I actually recognized a prior boss who actually helped me do that, and that is former Secretary Bill Hazel. So I had the opportunity after about 15 years of private practice, years of being in health policy through medical school, and some hospital administrative work to serve as state health commissioner briefly under Governor McDonald, and again my boss was Secretary Hazel. And at that time, the perspective that the office of the state health commissioner allowed me to see were some of the incredible disconnects between every sector, not only within health, but also as it heard the influences of the social determinants of health. And with me in primary care as a clinician, but also recognizing health policy and advocacy as some of the influencers and the perpetuators of some of those systemic issues, I felt like I need to do something and invest my time and energy. And I'm grateful that the administrators of Eastern Virginia Medical School recognize that as a graduate of EVMS, that is my home region, and recognizing my personal and professional experiences, that I was going to be well positioned to help EVMS to be able to connect those dots a little bit more intentionally, particularly because Eastern Virginia has some of the most significant health disparities, even beyond Richmond at times. Infant mortality, diabetes, even in our older population. So that has helped me be even more inspired to do the work that I'm doing. But even more so, the pandemic helped elevate the critical importance of recognizing that the community voices that are not getting the information, that are not getting access, that are suffering many times in silence, are those who suffered the most initially due to the pandemic. And I will say, because of Centera, Riverside, CHKD, Chesapeake Region, all the hospital systems recognize that they could not address and engage those populations because of a lot of the mistrust and distrust that preceded the pandemic. But it took trusted resources and trusted messengers within the community that happened to be a lot of my former patients, that happened to be a lot of my community members that I worked with, that helped open those doors, provide information, and to see the results of getting information, getting tested, getting treatment, and ultimately getting vaccination. So every day, a lot of what Sheryl presented is what inspires me. And for funders like the Androids Community Foundation, that I'm a board member of now, to have this opportunity to provide insight, education, and more importantly, trusting relationships is what motivates me to stay in this work.
Thank you. I think we'll come back and talk more about some of the community partnerships as we move. Pat, please.
Good afternoon. First, I would like to acknowledge Bill Hazel because he's a member of the board of the Northern Virginia Health Foundation. And some of the staff, actually 2 of the 3 staff, are here now as well. One of the things that prompted me to focus on health equity was the county health rankings. And the reason was because, quite frankly, it pissed me off. So what happened was that Northern Virginia always had wonderful rankings. There are more than 500 million people living in poverty in Northern Virginia. And folks said, you don't have to run because you came up number 1, number 2. And local jurisdictions, looking at opportunities to cut revenue, said, well, we don't have to give you a lot of money, we have to run because you're doing great, you're number 1 in the state. So actually, through a very complicated set of factors, found Steve Wolf at VCU and said, I don't want to look at county health records. I want to do it by census tract. I want to understand what it really looks like at a random level. And so we started a series of commission reports for VCU that actually demonstrate, not anecdotally, not hypothetically, but demonstrate where the problems are. Not just in terms of health outcomes in a clinical sense, but in a range of factors. So one of the things that we learned was that in the city of in Northern Virginia, there's a 13-year life expectancy difference between Alexandria and Dulles Airport. Really? It doesn't look terrible. It just is terrible. So understanding how to get that information out consistently, because it's not a one and done. People don't believe it if you want to tell them. Understanding how to get that information out became part of the work of the foundation. And it has influenced a lot of other factors, which I can talk about later. But the notion of saying just because you rank high means you have no problems is ridiculous.
Good afternoon. I echo much of what has been said because our journey with the Health Collaborative also started with the City and County Health Rankings. We had the opposite problem. Our communities continuously rank at the bottom of the list year after year. And it was actually our Chamber of Commerce, the director, that brought people together to say, look, these health impacts, these health outcomes are not just affecting people who are sick. They're impacting everyone in our community. It impacts our education system, our workforce, the business community, our economy. And so we really need to take this collaborative approach to bring people together if we're going to create an impact. And I think that really drove us to create health equity report. That's one of the big initiatives that the Health Collaborative does every couple of years. So our first report in 2017 really set out to demonstrate the impact of the social determinants to help people understand that it's one thing to tell people to change their behavior, to educate them, but much harder to do if you don't have those resources and opportunities in your community. And so this report, I think, really drove home the idea, again, that Sheryl laid out in her presentation, that place matters. And that was sort of the messaging that we were using at that time to say, look at the differences, the disparities in these communities. Where you live really matters. Since then, we've updated our report. So our most recent edition is 2021. And again, continue to see these disparities, similar patterns across the community. But this time we really dove deeper and said, well, why is it that one place is so different from another in our community when these neighborhoods are right next to each other, right? And so it really, really dove into the roots of, again, policies, history. Danville, it was the last capital of the Confederacy. That legacy, still persists in all of our work. And so I think, more than anything, this work has helped us bring people together across all different sectors, across different backgrounds and communities, really to create this culture of collaboration and shared learning, where I think the report and the data helps us ask good questions about why are we seeing this and what do we need to do to really move the needle and to reduce the gaps that exist within different populations in our community. And so, I think just from my own experience too, as someone who's not originally from the area and has moved here, I see the way that, it's been harder for me to manage my health conditions. It's been harder for me to find some of the resources I need to practice a healthy lifestyle. And I'm someone with a lot of privilege and a lot of access to resources and opportunities. And so the fact that that's not the case for everyone in our community and that it's even more difficult for some and has been for generations, I think is, it drives me and many others in our coalition to continue to do this work.
Thank you. You can see why we brought together these fabulous panelists for this conversation. I'm interested in how your institutions all have thought about social determinants of health. So certainly we're talking about life expectancy, we're talking about health disparities and inequities, and within this room there are institutions that focus on health and there are others that focus on education or workforce development or transportation. All of these issues are very much linked. So can you talk about if or how your institutions have thought about social determinants of health, sort of moving upstream in terms of navigating these issues? Anyone can start.
Well, I can go ahead. As the Jenkins Foundation, our history is in healthcare, and while we have done a lot of learning around social determinants of health, we also felt that we needed to recognize and honor the legacy and not necessarily leave behind partners that we had established over time. With that, it's still recognizing, of course, the importance of social determinants of health. And in our funding, we have also partnered with organizations that focus on housing and education, and brought in the healthcare and integrated the healthcare within those scenarios. So I think it's a mix, for us, both learning and acknowledging the importance of social determinants of health, but also recognizing that there is a role for healthcare and that we need to partner with other organizations that are addressing those social determinants.
Thank you, Jonathan, for asking this question. This excites me to be able to report on Eastern Virginia Medical School. So many of you may not realize that EVMS was built literally by the community, for the community, and has continued to be sustained by the community. As of July 1st, we'll be integrating into Old Dominion University, so we're going to become part of a very big family. But through the years, EVMS has acknowledged that the health of our community can only be improved if the health workforce looks like the community. And so we have been able to really work on pathway and pipeline efforts, and particularly strategic recruitment, so that we have a very diverse set of medical students and other health professional students as well. And just recently, we've been recognized as having the most diverse incoming class, not only in Virginia, but also have had the highest increase in diverse students across the country. So you all can take credit for that. I'll also say, particularly related to the social determinants of health, the AAMC actually initiated the conversation probably about 6 to 8 years ago to try to incorporate it into the medical school curriculum, allowing the students to better understand the social determinants of health. And I believe many schools across the country had a few hours in a certain course, or even a week, or maybe even a month. Well, at that time, EBMS took that charge seriously, and we were one of the only medical schools that started by incorporating this type of approach to influence and be a part of all 4 years of the medical school curriculum. So it started as service learning, but now it's called community engaged learning. So every medical student that comes into EBMS within the first week of them starting classes, they're all happy and smiling and well rested, but they have the opportunity to choose one of about 18 tracks that they will be a part of their entire 4 years. And those tracks are in partnership with Salvation Army, Union Mission, those experiencing homelessness, those experiencing incarceration, and the like. And so for them to immediately be introduced to those experiencing situations and circumstances in their lives that oftentimes are very, very, very different than all these students have ever seen or been exposed to in an intimate way. You can imagine over the course of, not even the first 4 weeks, but actually over the course of 4 years, that I believe that our students are very much interested in seeing how they can continue to be part of some of the solutions as they help their community become better connected to not only healthcare services, but also services and programs that can address transportation, education, and stable housing. So just excited.
Thank you. And I hear in several of the responses the importance of proximity and the importance of relationship, that it's not enough to simply be extractive. So we go in and do for, but it's very much about building the reciprocal relationships to be able to do with the community. What would you add around the broadening and thinking about social determinants of health?
So I need to first say that the Northern Virginia Health Foundation is a small philanthropy, and we don't fund government. So it struck me that if you wanted to look at social determinants and you needed to look at systems change, then you needed to go where the systems were. So I approached several local jurisdictions and said, we're not going to give you any money. And they laughed because they have heard me say that a lot. But if you were going to improve conditions and you had to work with a nonprofit, who would you work with and what would you do? And they began to actually think differently about how to change outcomes, not just clinical outcomes, but the health outcomes, the community's health outcomes. And so the foundation has 4, at the moment I think still 4, upstream, what we call the upstream interventions. Ways in which to think about community building, either in a very small way or a slightly larger way, that gives community empowerment, allows community to think about themselves differently, and allows them to build trust with local government. So there's one particular nonprofit that actually is doing, despite some early indications of being kind of flaky, is doing some really, really good work. And working with a local jurisdiction on things they never imagined they could do. And the local jurisdiction didn't think about it either. So they have learned to process, but most importantly, they've learned trust. It's not universal, it's not always consistent, but it's essential in order to think about improving social outcomes, because social determinants, just have to say that 20 years ago, health funders didn't get social determinants. Now we think everybody should get it really fast, right? It takes a while for people to understand.
Yeah, I think for us, it's been really interesting to see our community's evolution and their understanding of the social determinants. It does take a long time for people to grasp, but I think once you see it, then you can't unsee it, you see it everywhere. But I think since our latest health equity report, as we went out to the community and had these community conversations and dialogues about the data, people were saying things that we expected. If we want to improve community health, we need to improve our transportation systems, quality of our healthcare systems, education, neighborhoods. But we also heard this last time around that people were really interested in the process of how those changes are made. So asking things like, well, how is policy developed and changed? Who's really part of that work? Or who is deciding on what the city's budget looks like, and how do we have a say in that? Or where do we go, or how do we get involved so that we can share our lived experience and influence some of the decisions that are made, about these social determinant issues in our communities. And so that was really interesting to us, and it sort of led us down this rabbit hole of civic health. And so I think sort of the way we've been thinking about it lately is that the social determinants are driving our health outcomes, but it's civic engagement, civic participation, and infrastructure that's determining what those social determinants look like in our communities. And so that frame, I think, has really resonated with a lot of people, and I think has helped bring others into the conversation that didn't necessarily see themselves or the work they do as connected to health, but they get it if we're talking about civic health. And so that's been really interesting just to sort of see how that continues to play out in our community.
So I appreciate in the examples that you all are sharing the importance of asking questions and also asking the right type of question that's going to bring the community in, that's going to explore data in a new way, that's going to redefine how we as a board think about certain words or concepts. So we have just a few minutes left, and I'm wondering if you can share some advice for foundations that might be in various places along this journey. Knowing that if we're dealing with the residue of 400 plus years, this isn't going to be an overnight fix. What are some of the steps that institutions can take that would help them to make a difference in terms of advancing health and racial equity? Any advice you have as we wrap up our time together?
Go ahead and start again. But I would say that the first thing is to look at yourselves. Look at your own organization and who's on your board, who's the staff, and how you can really structure the composition to reflect and understand the communities you serve and be closer to the communities you serve. And by that, I think that I'm personally in the Richmond region. We have many, many diverse communities, some that have been here for generations and others are new. And so we need to, if we're talking about health equity and enabling everybody to reach their highest level of health, we are talking about creating spaces for all of those communities to thrive. And so being aware of who they are and how we then can structure our own organizations to become closer to them. That would be my top advice.
So I would simply build on that and say you could follow an example of what the Honduras Community Foundation does, which is gets to know the community a little bit better.
So Dr. Linda Rice, who I believe is speaking later on this afternoon, is our Vice President for Granting, and she conducts with some of the other community foundation staff these affinity groups, one around mental health, one around experiencing homelessness, etc., and getting to know particularly many of the nonprofits that are out there doing some tremendous work. But I think we were talking earlier about capacity building. And in addition to recognizing what the issues and who the players are within the community, it's helping to build the capacity so that these nonprofits, these community leaders within faith-based organizations, public housing, any of the other organizations throughout the community, they have good intentions, but may not know about how to complete an application, how to know the difference between a process metric and an outcome. So to engage them, better understand, but also help them to build the capacity. And then the last advice would be to even consider longer term investments in these type of initiatives. Because clearly, as we've heard, for 400 years, to influence a lot of the system changes, we also have to recognize that there are probably centuries of biological and genetic impacts that are happening within individuals and communities. And that's physiologically, but also relationship. And oftentimes it takes a little bit of time, patience, but also natural facilitation. These groups that come together, work together, and to really determine what are some shared outcomes that they can all strive to accomplish together. And take advantage of academic medical centers that are a little bit stuffy with IRBs and visual studies like that, but better understanding how the communities really would like to see some of the outcomes really achieved, and to see how everyone from different sectors can actually contribute and support to those.
I think I would say, when you're talking about health equity, think about it as a healthy community. Stay away from thinking exclusively medical health, which is the general default that people go to. It's not medical health, really. Second thing I would say is don't think that racial equity is a project. It's gotta be embedded in everything you do. So if you do housing, there's a racial equity issue related to housing, also transportation, education. I mean, you guys know this. But it's too easy to say, well, you know, we used to fund the arts and now we don't fund the arts anymore. Don't say we used to fund racial equity and now we don't fund racial equity. Don't. So that would be my advice, because if you just embed it in your work, then the outcomes start to happen. If you think of it as a project, then you have to figure out all the time how to make it work. It doesn't work.
Yeah, I would say I think the Health Collaborative has been able to sort of be this neutral convener in our community, and so we provide this space where people can show up and feel like they can have courageous conversations, and they can be around people who are different from them, and it's a space of learning, and we're all figuring it out together. I think, you know, early on, I heard people say things like, well, you're talking about health equity, you might not want to use the word equity, or you might want to, you know, stay away from some of these phrases that can turn people off right away. And I think that since we have more explicitly talked about structural racism as you know, as the driver of health disparities, I think that's when we've seen the most participation in the collaborative. I think people in our communities want to talk about these things, and they're looking for opportunities to be around people who are having real conversations about real ways to create change. And so I think, yeah, my advice is just, you know, be courageous, and when you do that, I think the right people show up to the table. And you know, in our community, I feel like the momentum is just growing so much, and I think it's empowering more and more people to go back to their own organizations and talk about these things, using these big words. And I think just, overall as a community, I think it's helping us all be more effective in the work that we're doing to advance health for everyone and health equity.
Can I add just one more thing?
Please.
One of the things that I find fascinating about philanthropy is that there are moments when we think, because we have the money, we can fix it, but we actually can't. So funders, in my view, need to figure out how to develop relationships with local governments, with state governments, and with the private sector. Please remember that a number of people from the private sector sit on your boards. So how do you engage them in being advocates with you in their communities? But it's really important to understand that if you want, it's sort of like Billy said, robbing banks, you go where the money is. If you really want to affect change and change dollars, you got to deal with the government. You absolutely have to do it. And starting at the local level is really effective.
And just,
Really,
I'll
really
just
last
add
comment.
one, exactly. In addition to that, also engage the individual you're trying to serve, the populations that are really suffering that may not have.
So I'm struck in this conversation by two frameworks and two thoughts that my colleagues and I at the Virginia Center for Inclusive Communities use a lot. One comes from the disability justice movement, which says nothing about us without us, which is such an important way to think about how we're engaging communities in truly authentic, reciprocal ways, nothing about us without us. The other model comes from the work of Brian Stevenson, who's the founder of the Equal Justice Initiative, I think a prophetic voice for our time. And he talks about a pathway from proximity to relationship to empathy to justice. Proximity, relationship, empathy, justice. And that process to go from relationship to empathy, I think, is so much about asking the right questions. It's about building the trusting reciprocal relationships, leveraging the data, and then that allows us to be able to work to create justice. So to the Weisberg Foundation, to Sheryl Garland, and to our tremendous panelists, thank you for the work you do to advance justice. We are grateful. We have time for a few questions from the audience. So if you are a brave person who doesn't mind raising your hand and forming your comment in the form of a question, we would be grateful for that. And Bess has the microphone, so please raise your hand and we'll do our best to get one or two questions in from the audience.
My voice isn't that strong. Any
Thank you, my colleagues, thank you so much. Good afternoon and welcome everyone to the third annual Virginia Funders Network Conference. We look forward to giving a hand to the outstanding VFN small but mighty team that has pulled this off. My name is LaShawn Atkins-Rowan. I have the honor of leading the Weisberg Foundation.